So welcome everyone, and welcome Shaun Gallagher to Hobart and to the University of Tasmania. And I just want to express, our thanks again for delivering the Martineau yesterday evening. And we had some great discussions around ethical expertise. And Shaun added to the account that had been sort of built by Dreyfus by adding Varela's correctives to that account and considering the notion of the good, which was an important missing element in Dreyfus's account. So that was great. And this morning we have you here at the university's Sandy Bay campus, and we're going to look at another angle of your philosophy, particularly in the domain of the philosophy of psychiatry. And recently you've just published another book, which is specifically in this domain, The Self and Its Disorders, and this is with Oxford University Press. So congratulations on that.
Thank you.
And we're going to look forward to discussing a bit more about that book in this particular session. So you begin in the book, in the introduction, with a discussion of John Dewey's prescient account of the problems with the medical view of ill health. And this has already been identified somewhat in Carl Jasper's work, the phenomenologist and psychiatrist of the early 20th century, with regard to mental illness. And that in both the accounts of bodily ill health and mental ill health, that there's a kind of a reductive physicalist approach, and this has dominated and led to some significant distortions in the understanding of both medical disorder and mental disorder. So, and these have all contributed, particularly in the domain of psychiatry, of course, to the crisis of legitimacy in psychiatry, and this is persisting today, and there's still work being done on this. And what is needed, of course, is a more encompassing interpretive framework rather than just what is now put forward as the biopsychosocial model. And that promised to address a lot, but of course, many psychiatrists themselves are criticizing this and saying that, in fact, it is just the bio model still. So there's still that physicalism that is dominating. And so the great innovation that has come out of phenomenology particularly is this idea that mental disorders are better understood as disorders of the self. So let's pursue that a little bit further and look into how you have developed that on the basis particularly of your notion of the pattern theory of self. So, but before we get into that kind of territory, I'd just like you to tell us a little bit about your background and how you came to philosophy and particularly phenomenology and in activism.
Okay, yeah. Well, thank you very much for inviting me here. It's really a beautiful place, and I'm enjoying it. My background, I would say, as an undergraduate, I started to read the existentialists, especially Jean-Paul Sartre, and by the time I got to a grad school, I wanted to know where those existentialists came from, and the idea was that they were quite influenced by phenomenology, especially Husserl, Heidegger, and so forth. So I really studied phenomenology when I was in grad school, and my PhD dissertation was on the notion of embodiment and temporality, especially in the work of Merleau-Ponty. So this was a bit before the whole notion of embodied cognition was sort of in play. And I feel like I was not only reading Merleau-Ponty, I was reading the empirical literature because Merleau-Ponty had also read that literature. So I was looking at psychology and neuroscience and trying to, in a certain way, update Merleau-Ponty in terms of the empirical stuff. And pretty soon I guess what I should say is that it really depended a lot on the people that I met. I think I was very lucky to meet the right people at certain times in my career. And meeting those people really allowed me to see the potential of phenomenology to address issues in cognitive science, but then also in psychiatry. And of course, there is a long tradition of phenomenology, phenomenological psychiatry, going back to Jaspers, as you mentioned. And so I started to read quite a bit in that area. So really, it's my background in phenomenology, kind of opening up to the cognitive sciences that sort of led me to this area of considering mental disorders. Yeah.
Great. So, one of the aspects, of course, of recent sort of work in phenomenology and in activism is the 4E account of cognition. So, how do you think that helps us to reconfigure the problems in psychiatry, particularly, and psychology as well?
Yeah. Well, you mentioned Dewey in the beginning, and I started with a quotation from a lecture that John Dewey gave in the 1930s to the College of Physicians in St. Louis, where he was telling the physicians, you should not simply focus narrowly on the physical body as a kind of mechanism that needs to be fixed when you encounter a patient who is ill. You have to consider, he said very explicitly, you have to consider the environment. You have to consider their lifestyle, where they are living and what they are doing. So the idea was if you are diagnosing someone with lung disease, you don't give them medicine and send them back into the coal mine. You have to consider that it might be, in fact, their way of living that has something to do with their illness. So to me, that sort of opens up, takes a wider view, and that certainly informs psychiatry starting in the 1980s, I assume, with the what is it called? The
4Es.
No, I'm thinking about in psychiatry the psychosocial.
Oh, right, yeah.
Biopsychosocial, model.
Right.
Where the social, of course, Dewey was also very much into the social environment. The phenomenological approach, again, has been around for quite a while. And I suppose in a similar way, I think that phenomenologists are very interested in the lived experience of the patient. Not just in their body, not just in their brain, but in the way they interact with others in the environment, the workplace, their home life, and trying to take that more holistic approach, I think, is very characteristic of the phenomenological approach. The 4Es then seems to me to be, again, on the same track of saying, well, we have to consider the body, but also we have to consider the environment, how our mental life extends into the environment or is supported by, scaffolded by environmental features, and how our interactions with other people are so significant in terms of our mental health that the 4Es, I believe, really form a good foundation for thinking about psychiatric problems.
Yeah, great. Yeah. So this has been taken up a lot in particularly Europe, and I'm thinking here of the work of Joseph Parnasse and Thomas Fuchs, and known psychiatrists, well-known psychiatrists and phenomenologists. And with the works particularly of Joseph Parnasse, he talks a lot about the minimal self or the basic self, and particularly with regard to schizophrenia. So I think, in your recent work, you're challenging that kind of just focusing on the minimal self and saying there's much more to be told than that, and drawing on your pattern theory of self. So can you tell us a little bit about that?
Yes, okay. So Parnasse and the group in Copenhagen and again Thomas Fuchs in Heidelberg, they have done a good amount of work on schizophrenia, and they think of schizophrenia as a self disorder. And when they think of the self, they think of the self in these terms of the minimal self, which is there's a great debate right now about the minimal self, what it is, and exactly how one can think of it. But if we think of it as sort of the embodied sort of immediacy of our self-experience, phenomenologists like to talk about pre-reflective self-awareness, and that's sort of the core idea of the minimal self. So something goes wrong with that aspect of our experience, that pre-reflective aspect of experience. Parnas and his colleagues call this ipseity, kind of the immediate selfhood. I think there's some truth to that, and it's certainly not something that I'm setting aside, but that may be helpful in explaining schizophrenia, but of course there's a whole range of different possible psychiatric disorders that need to be considered. And the argument of the book is that all of those psychiatric disorders are, in fact, disorders of the self, except that we have to understand the self in a much wider sense. So that's where the pattern theory of self comes in. If we think of the self as a pattern, then it's a pattern of different processes, different factors that include the minimal self, a kind of embodied and experiential aspect of self that sort of comes under that heading of minimal self. But it also includes our affectivity, our emotional life, our cognitive abilities, as well as our reflective abilities, our actions and behaviors, our narratives, our social relations, the normative factors that enter in and start to shape the way we behave and think about ourselves, and the environmental factors that might in fact shape our self-experience. So what I want to do with the notion of a self-pattern is to try to see how all of these factors come into play. And if we think of the pattern as something like a gestalt, and specifically a dynamical gestalt, then we're thinking of it in terms of how these different processes interrelate with one another. So when we think of psychiatric disorders as self-disorders, we have to sort of take a look at the whole pattern of factors and try to see, which of those factors or some number of factors might be the kind of core problem in a particular disorder, and try to address say, therapeutic practices in a specific way towards trying to adjust certain things within the self pattern.
Great. Yeah. That sounds fantastic. So one of the elements that you're mentioning there is the narrative component, and you were proposing that this also serves a very special role within the pattern theory of self. So can you explain why it is special?
Yeah, I think there's a lot of work in philosophy on narrative, and a number of people have suggested that the narrative self, or that narrative aspect of our self-experience, is central. We are the stories that we tell about ourselves, and we include the stories that other people tell about us in this conception of self. And I think that's definitely one particular type of process within the self pattern. And it's something that we should consider seriously. It's not the whole story, however, so I don't want to reduce the notion of self to just the narrative self. There are all these other aspects that I want to include there in the self pattern. But at the same time, I think that although it's one particular element within the self pattern, it's also a special element in the sense that it reflects all of the other elements. It is, my narrative about who I am will tell us something about my emotional experience, my relationships with other people, the kind of normative pressures that I might be feeling in the workplace. It will tell us about all of the other aspects that we've considered to be part of the self pattern. And so it's something like a window into the self pattern. It's something that allows us to see precisely what might be going on. So the idea would be for a type of narrative analysis that would try to get just at those other aspects of the self pattern. And I think there are a lot of narrative approaches that will give us tools to analyze not just the content of our narratives, what we say about ourselves, but also how we say it. So even syntactical structure of narratives start to reflect some of the disorders that we're considering.
Have you got an example of that?
Yeah, I mean, there are studies, and in the book I point to empirical studies where people with certain disorders, including schizophrenia, for example, they will start to tell that their narratives start to become impoverished. They start to use the first person pronoun less. The syntactical structure of their sentences can be studied to see that they've changed over the course of the progression of the illness. Similar kinds of things can be looked at in, say, depression. So I know there's empirical studies of the narratives of people with depression, which also reflect certain syntactical differences. So you can look; it's almost like something like a kind of fingerprint of the possible disorder, reflecting. Let's say if it's reflecting some problems in terms of emotion regulation, for example, that's going to show up in the narrative, and we're going to be able to do an analysis of the narrative. And this is again ties into phenomenology and the idea of trying to get at the lived experience of the person in terms of them giving you a narrative about what they're experiencing and taking that narrative and that experience seriously. And it seems to me that this would be the basis for a more person-oriented type of psychiatric practice, where it's more a practice of really focusing in on that person's experience, how they're expressing that experience, and having that as a starting point, rather than saying, we'll go directly to the DSM and find some kind of checklist that will tell us whether this is schizophrenia or depression or what have you. It's rather starting with the patient and trying to see what aspect of their self-pattern seems to be problematic, and then trying to formulate therapies on the basis of that.
So do you think then that the categories of the DSM or the ICD then become redundant? Or do we still need those to be in place alongside something like a pattern theory?
I wouldn't throw those books out. I think that they probably capture something about some of the problems people are having. But I think anything like an automatic reliance on simply a kind of checklist, whether it's based on the DSM or some other diagnostic tool, that's something that happens maybe too frequently, at least I think, especially in the United States in psychiatric practice. And it's a matter of, here we've identified the illness, here's the drugs, and see you later. And
I know. Well, it becomes that it's almost like they're reliant on the checklist in order to get any kind of treatment regime happening or access to insurance, to welfare. So they've got to qualify in some kind of category.
Yeah.
So it's
so this is,
this is problematic.
It's a very complex thing, psychiatric care, because you have a patient's perspective, you have the psychiatrist's perspective, and you have people who are paying for the treatment, government agencies, and everyone is looking at these issues from different perspectives. And I think the starting point should always be with the patient's own experience in this.
Yeah. So the pattern theory does that. Now, one other sort of very crucial aspect of the pattern theory is the dynamic nature of it. And so what happens when one aspect of the pattern changes? Can you explain how that works in mental disorder?
Yeah, so on the pattern theory, the idea is that any change or intervention on one particular aspect or one particular process of the pattern will have an effect on the other aspects. So if and you can think of this on the side of trying to understand what the disorder is about, but also you can think of it in terms of therapy. I mean, if you can intervene on a particular aspect of the person's self pattern, it's possible to intervene on one or more aspects of the self pattern that would address some of the problems that a person is having, which opens up I think a wider field of therapeutic practices. So it could be that you want to intervene on embodied processes, and things like movement therapy, dance therapy might allow you to do that. You might want to focus on intersubjective relations, and there are group therapies that might help in that respect. There's especially here in Australia, there's narrative therapy. So you might, in fact, decide that the intervention can be successful by looking at how we can reconstruct the narrative of the patient. So there are all these different types of therapies that studies have shown that they all work in some degree. And of course, the therapist oftentimes uses a number of those different therapies to try to understand and help the patient, which I think is just fine. In terms of what an illness or what a disorder can do, it could start as a problem having to do with affectivity, emotion regulation. But that, of course, can lead to, for example, insomnia, which would be a bodily, affectivity, of course, is already embodied, but there can be other physical problems that come with that, and that can interfere with cognitive issues that then ultimately might be cashed out in kind of narrative practices. So the idea is that any particular change in one process in the pattern, because there are dynamical relations between all of these processes, will affect the whole, at least above a certain threshold.
Okay, so interesting. Another aspect in your book is looking at artificial intelligence. You've got a whole chapter on that. So I'm wondering what you've got to tell us about that and psychiatry.
Yeah, so there are AI-assisted therapies. These have been around for a while, but of course now they're really, taking off because of the real progress that has been made in artificial intelligence. So there was a program back, must have been in the 70s or so, ELIZA, the ELIZA program, which was basically it was a chat box. And it was a very basic one that you would tell Eliza something, and Eliza would simply ask, "Oh, tell us more about that." So it was very, very kind of Carl Rogers sort of therapeutic situation. But now there are more advanced versions of this, and so people are going online in some cases, and interacting with chat boxes. And some of these chat boxes are quite sophisticated, and there can be problems that come along with that. So there are some chat boxes that, in fact, are designed with a particular goal in mind, and they will lead the patient on a certain trajectory towards that goal. And they're not really designed in such a way that adjustments can be made in that, so that some of these chat boxes become very rigid. And that's not good, because this kind of rigidity doesn't take into consideration changing circumstances of the patient, for example. So there's a question, I think, an important question about transparency with respect to the artificial intelligence programs that are being used here, and whether we truly understand what they're doing to us. So how they work, we don't fully. I think it is also clear that in much of artificial intelligence, we don't really understand how these systems work. Even the engineers are somewhat puzzled about some of the products or some of the results. So there's a kind of epistemic lack of transparency, and that might be fine, but I worry about what I've termed hermeneutic transparency, and that is understanding what these systems are doing to us as we use them. And I think that's a general worry with respect to artificial intelligence, but I think it also comes to play a role in the AI-assisted therapies. We should really understand what some of these chat boxes are doing, and it's possible to work out some way that perhaps you can make a chat box more flexible and start to follow the patient's own trajectory. But then it's not quite clear that would avoid something like a loop back into the patient's own disorder. So it's not clear that that's going to be a solution. So I'm not quite sure what the solution is at this point, but something to worry about.
Yeah, absolutely. Yeah. And also possibly dependence as well, that humans become dependent on the chatbots rather than seeking real social engagement with other human beings.
Yeah, so what my view is that you can use these chat boxes, but they have to be guided in some way by real psychotherapists, and that interaction with psychotherapists somewhere in this process is going to be important.
Right. So, yeah, an important safeguard.
Yeah.
Okay, so I think we could now open up to the floor for questions. Anyone online or in the room, if you'd like to put a question to Shaun, I'm sure he'd be very happy to answer you. Yeah. So
let's start.
Shay.
Hi, Shay.
Hi, Shaun. How are you?
Good. What time is it there?
It's 8 o'clock. I feel like I'm stalking you around Australia right now. So, I love everything that you do. And you know that I'm very critical of this whole project. Like, not your project, but the whole thing, right? So I have a question, and maybe you have an answer. Mm-hmm. So you just mentioned that, we need to be concerned about the fact that we don't quite know what AI is doing, and that there needs to be more transparency, and that, it could lead the patient in actually targeted directions, or if it follows the patient's own narrative, it could just loop the patient back to their disorder, right?
Yeah.
But, and that this is my concern, right? That I don't see why psychiatrists have any less of that problem, right? So psychiatrists always have sort of their own approach or their own metrics for success or health or any of those kinds of things. And it seems like psychiatrists, because we're thinking about the self being disordered. And when we think about cognition being embodied, it all has to do with training and habituation or developing the narrative self. So psychiatrists tend to habituate the patient away from themselves, right? And in a sense, their goal is to eliminate the authentic self and habituate a self that they think is more tolerable by themselves and others, according to some kind of metrics.
Mm.
And so I'm wondering, since the projects tend to be interested in, what kinds of prescriptions can we make for clinical practice? How do we intercept this issue, right? Because it is the case, like in madness studies, when people who are disordered try to account for their relationship to their self and what kinds of therapeutic measures work for them, psychiatrists come back and they're like, nay, you don't understand yourself, you're so disordered, right? And so they just completely dismiss all of the people in madness studies who are like, don't pathologize me, don't medicalize me, right? All these kinds of things. So I guess, and we do know that people will hit an extreme or like an end point where something needs to be done. So how do we, and this is a long conversation, I'm sorry, where do we meet in the middle, right? So how do we actually attend to the phenomenological embodied self of the patient and not have it retrained and rehabituated by the desires of success of the psychiatrist?
Yeah.
So that the self that was there is no longer there. It's just the new and improved, socially acceptable version of a self.
Right. Yeah. So, I mean, this is a large question. Might have to do with training of psychiatrists and so forth. When I talk to therapists, my sense is that it will depend, of course, on the therapist, on the psychiatrist, but a lot of them are quite open to different methodologies, different approaches. A lot of them, especially the ones I find I meet in Europe, I meet a lot of people in Europe, and less so in America, are open to multiple practices. So movement therapy, talk therapy, and doing a lot of things, before they start offering drugs or medications. And it's in America, I find it's a little bit quicker to go for the medication. But I think that flexibility, at least in terms of the possible practices they use in their therapies, is good. And of course, the problem of trying to understand the patient is, I think, what phenomenology does. At least that phenomenological approach does concern itself with trying to understand. Whether we have normative biases about what a self should be like, or what an authentic self looks like. I'm not even sure there is anything like an authentic self in any way. I think we have so many different factors that enter into it, and a particular person may look like this type of self in one context and another kind of self in another, depending on who they're interacting with. I think it's a hugely complex issue. And when psychiatrists and therapists get involved, it just makes it more complex. But if the therapist is open not just to the patient, but also to family, friends, a more social, and there are, in fact, now psychiatrists working with teams, looking not only at the patient, but also at their environment, their social relations, and then trying different things to see what works best. I don't know. It's not a science. This is probably part of the problem, I think. It's not really a science, more of an art, and informed by medical science, I suppose, but still something of an art, and that makes it difficult.
Okay.
Okay.
Thanks, Shay. Thanks, Shaun. Jack.
Hi, Shaun. How you going?
I'm good. Jack, how are you?
Good. I'm stalking you from a different state, not a different country. But my question, I think, is a little bit related to Shay's. I'm really just interested in if you think there's a way of accounting for, let's call it, maybe we don't want to use the term disease, but pathology, in terms of the structures or the patterns of the structures themselves. I mean, obviously, following on from your talk last night, suffering might be a criteria, but is there a way in which, if we talk about the patterns themselves, because obviously there are infinitely many patterns, is there anything about the patterns which is suggestive of, not to use the medical language too much, but dysfunction or disease, or is that not the way you want to go with this?
Well, let's say in a clinical setting where someone is interviewing the patient and paying attention to their lived experience, it's oftentimes the patient who's going to tell us what's wrong. It's going to be something like a complaint that they have about their life, or it could be much more apparent in, say, for example, the case of schizophrenia, where they're really having delusions, something like that. So, in some sense, we can think of this as, well, in a particular case is going to be some aspect of the self pattern, or some aspect of the sort of dynamics involved in the self pattern that seem to be leading to this particular problem that the person is having. So I think just that is something to work with. It gives us. I'm a philosopher. I don't work in the clinic, so it's not us, but it's the psychiatrist. It gives a psychiatrist or the therapist something to work with, and they have to begin, it seems to me, with that, and then work from there, and try to be as open as possible to what the patient is telling them and how the patient might be treated for that problem. Do we have to bring, the kind of diagnostic classification in and say, now what we have here is schizophrenia? That itself, of course, if you just say to the patient, "Oh, you're schizophrenic," that itself kind of layers on something extra to the patient. But for the psychiatrist, it still might be useful to understand that somehow or other this really looks more like schizophrenia than borderline personality disorder or something like that. So I don't want to totally dismiss something like the DSM, but it should really be something back here for the psychiatrist to look at after their attention has been sort of on the patient and finding out what's going on with them.
Mm.
Does that answer your question?
Yeah. On a related kind of point, we've got the issue of looping effects, haven't we? Of, when someone is diagnosed as having a particular disorder,
Yeah.
and then they come to identify with that, and it.
Ian Hacking had that notion of looping effects, which I think is right. A great one. Yeah, and you can see in some of the interviews of patients where they will start to explain what they're feeling and so forth, and then they'll suddenly realize, oh, that's my schizophrenia talking.
Yeah.
It's not really me. And then there's that's not a very helpful. They get a kind of distance from themselves, and that could be more leading to more of a dissociation than something like a way to deal with it.
Okay, so any other questions online? Okay, back here, Joe.
Just responding to what was just discussed then, how does this relate to antisocial personality disorders where the client does not recognize that there is anything wrong or in their behavior, not to have that realization of, oh, that's my schizophrenia. They lack that engagement to have that kind of epiphany.
Yeah.
I just wanted to know what you had to on that.
There are lots of interesting, issues there. Borderline personality disorder, for example, they can be very antagonistic and not really want to work with the therapist, for example. And sometimes that's where something like a chat box might actually work, where they can, they might feel more comfortable interacting with a chat box than with a therapist. And that might be a way for the therapist to try to get the person into a more therapeutic practice. But yes, certainly one can ask about antisocial or asocial type behaviors and how one might go about treating people with those problems. And then I think it just depends on what we're talking about or what exactly the issue is. There are aspects of autism, for example, that involve sort of a lack of social interaction. And then, something like, there have been actually therapies that involve children with autism interacting with robots and ultimately kind of drawing them into a kind of interaction that ultimately can lead to an improved interaction with other people. I think the therapists have a lot of tricks in their bag, and it's a growing set of tricks too, in the sense that artificial intelligence and robotics might in fact give them more tools to use. And to the extent that therapists are open to the plurality of different tools that they have, I think that's good. If they are sort of narrowly focused on just one type of practice, then that's not necessarily the best thing. Yeah.
There's a question from Sion Nila. So it was nice to listen to you. I am interested in studying in my lifetime suicidal ideation, specifically chronic suicidality, and self-harm as embodied phenomena through a phenomenological perspective. I was wondering if you had any suggestion where I could start. And more immediately, I am considering studying the phenomenology of self-harm or procrastination using mixed methods for my undergrad thesis. Do you have any suggestion for me regarding this? Also, do you think I can even hope to do phenomenological research as an undergrad with limited exposure to the subject, as I only see postgraduate or doctoral scholars working in this field?
Okay, well, that's a good question, and I would suggest that, as an undergraduate, for example, someone may not be in a position to do anything like direct research, but it seems to me that to the extent that you could get associated with a group that's doing research that you're interested in would be the best. And that would mean going and volunteering and trying to hang around those people and see exactly what they're doing, if that's possible at your institution. I think that to me, it should start out as a very kind of informal type of process where you're simply trying to hang out with people who are doing what you'd like to be doing, and then seeing how that works. And then opportunities might come up just in that whole practice. And certainly you could find better advice from people like that than from someone like me on this particular question. So I would really go and look for those people that you'd want to work with in the end, or people locally that you know are working in the same area, and then just hang around with them and see what you can do.
I had a question which build up on some of the element we touched about when you use the example that it's not me talking, it's my schizophrenia talking through. So I was wondering how the self-pattern tool or model is actually make it easier for psychiatrists to identify the blurry line of competence. Legally speaking, ethically speaking, in terms of clinics, that's a very fragile line to establish.
Yeah.
And is it actually enhancing their capacity as to pinpoint exactly where the self-understanding start, or is it something that?
Yeah, that's that's really an issue I haven't really thought too much about. So the whole idea of judging competence or incompetence, which is a very practical issue, oftentimes in the practice. Yeah, so I often use in the book. I often use this phrase above a certain threshold. And say an intervention on the self pattern above a certain threshold will then trigger perhaps some other types of changes in the self pattern. And there's certainly a way that you could look and ask how many of these processes are at stake. So there could be something like a central problem with one aspect or one process within the self pattern that leads to really a kind of breakdown of the pattern itself. So I'm thinking here, and there's a chapter in the book about the use of solitary confinement in prisons, where it just looks like, if you start looking at the reports of the people who are experiencing this, it looks, of course, like it starts with an issue having to do with social intersubjective interaction, because that they're basically being deprived of that. But that turns out to be extremely important, an important element within the self pattern. If you take that away, all kinds of other things happen. So you get a whole menu of different symptoms that have to do with our perceptual experience. So cognition is affected, emotion is affected, people's bodily physical health starts to deteriorate, and really they lose so much simply by being deprived of kind of intersubjective interaction with others. Well, you can see that could lead really to a complete incompetence, where it becomes so dramatic that all of the aspects of the self pattern are affected. On the other side, you could have something like, a problem that someone is having, but they have a really good support system. They have a really good set of friends or family who are supporting them. They are able to work, but they have a kind of circumscribed issue that they are trying to deal with. In which case, that would not lead to anything like incompetence. So again, looking across all of the different factors, asking how much of a change is happening across all those factors, that could at least give you some indication of how you might judge competence or incompetence, which is always, of course, a judgment call.
We have very drastic consequences. Forced treatment, for instance, abuse. Yeah, it's quite delicate.
I mean, one thing I think the pattern theory does is it sort of opens up the possibility of considering many different aspects of a person's life, so that you're not narrowly focused on, you're having cognitive problems. Let's try to fix those cognitive problems without considering the other aspects, right? So if you start thinking about the self as a self pattern of these other aspects and how they're all interrelated, it seems to me it just opens up the field of inquiry, and the psychiatrist then would have to be concerned about considering how this person's intersubjective life is structured, what their emotional life is like, are they suffering any physical problems, and so forth. So I think that's part of what's being suggested here.
Mm-hmm. Well, thanks.
Okay. Yeah. Okay. So, any other questions before we wind up? Last opportunity. No? Okay. Well, look, thank you very much, everyone. And thank you very much, Shaun, for being here.
Thanks, everyone, for hanging in there and being online. It's wonderful to see everybody.
Yeah. Great.
Thank you, everyone.
Bye-bye.
Bye. Very nicely done.
Thank you all. Thanks for your support here.
Thank you very much.
Nice.
Thank you. It's great.